Well, good morning, everybody. I am Dr. Laura Lacher, and welcome to Medical Grand Rounds. We'll go ahead and get started with some reminders, logistics, and then introductions for today. Next week, we will be hearing the talk Animal Hazards of the Northwest, given by Dr. Tom DeLowry from OHSU. Should be a fun talk here in person at Providence St. Vincent, so come on down and join us. Grand Rounds is a joint effort between those of us here at Providence St. Vincent and also Providence Portland Medical Center. We had a couple recent virtual Grand Rounds, but we are often here in person on Tuesdays, including next week. You can always watch on Teams Live, and you can also watch a recording of the event. The recording is the same link as the Grand Rounds invite, and you can earn CME credit for any of those viewing options. I'll be keeping an eye on the Q&A throughout today's session, so go ahead and post any comments or any questions for those of you viewing online. I'll mostly hold those until the end of the talk as time permits. And now to introduce today's speaker, we are joined by Dr. Abby Fry. Dr. Fry is a clinical pharmacy specialist with Providence Medical Group, where she provides collaborative management of chronic disease, including diabetes. She also serves as a drug information resource and is also involved with the education of internal medicine residents, pharmacy residents, and students. Dr. Fry attended pharmacy school at the University of Washington, followed by 2 years of residency with Providence Health and Services here in Oregon, as well as Southwest Washington. In addition to her clinical work, Dr. Fry enjoys editing the clinical pharmacy department's drug information newsletter and lecturing at Oregon State University College of Pharmacy. It is an absolute gift to work nearly daily with Dr. Fry, and I am so grateful for her skill and her generosity in teaching. Thanks, Dr. Fry.
Thank you, Laura, for that nice introduction, and thanks to all of you joining here today in person and online. It's always a pleasure to be back and do Grand Rounds. So as Laura mentioned, our department, the Providence Medical Group Clinical Pharmacy Department, publishes a periodic newsletter where we aim to provide timely updates and summaries of clinical trials, guideline updates, recent FDA updates, new drug approvals, warnings and alerts, as well as clinical and prescribing pearls that are relevant to primary care. I have nothing to disclose, and the objectives both of our RX Hot Topics newsletter as well as today's Grand Rounds are to evaluate recent studies that provide pertinent information about medications, to identify emerging safety concerns with commonly prescribed drugs, and to discuss new evidence that clarifies the roles of established therapies. Specifically today, I'm going to take a look or present 5 different topics. Talk about fezolinetant, which is a novel medication to treat vasomotor symptoms caused by menopause. We'll look at some of the noteworthy changes in the 2023 Beers criteria update. We'll look at the recent evidence regarding bempedoic acid for primary and secondary prevention of cardiovascular disease. We'll talk about beta blockers after myocardial infarction. Who should we be prescribing these for and how long? And then finally, don't think I could call this a Hot Topics Grand Rounds without talking about a GLP-1 agonist. So we'll look at semaglutide for patients with a history of cardiovascular disease or HFpEF and obesity. So I'll be using cases to help illustrate these topics, and we'll start with this one, Carol. Carol's 54 years of age. She has a personal history of breast cancer. Her last menstrual period was 2 years ago, and she's currently experiencing significant and frequent hot flashes, night sweats. It's affecting her sleep, causing fatigue, and starting to affect her work, and she's hoping you can help. There was a great Grand Rounds a couple of months ago regarding the treatment of menopausal symptoms, so I'd certainly recommend rewatching that if necessary for all sorts of details, but just in terms of a brief background, 80% of menopausal women have vasomotor symptoms. The mean duration is long, 7 to 9 years, but a third of women will have vasomotor symptoms for even longer, for more than 10 years. Hormone therapy is the most effective treatment for vasomotor symptoms, and I think we'd all agree probably underused, and kind of growing support for how we can use it safely. There is a racial disparity in this area. Black women are more likely to experience severe hot flashes as compared to white women, but are less likely to receive hormone therapy. Although hormone therapy is the most effective treatment, there are, of course, some absolute contraindications to using hormone therapy, namely prior coronary heart disease, stroke, MI or history of VTE, a personal history or inherited risk, high risk of thromboembolic disease, a history of breast cancer or other estrogen sensitive cancer, as well as undiagnosed vaginal bleeding. In addition to these absolute contraindications, there are some patient factors that modify cardiovascular risks of hormone therapy. And the factors that are going to lead to more risk include LDL over 130, a high cardiovascular disease risk at baseline, age greater than 60 years, as well as folks who are greater than 10 years since menopause onset. Of course, on the other side of that equation, if they have a lower LDL, a lower cardiovascular disease risk, younger age of 50 to 59, or less than 10 years since menopause onset, hormone therapy is associated with less risk. So treatment should be individualized, using the best available evidence to maximize benefits and minimize risks. And it's generally accepted that for women without contraindications who are less than 60 years of age or within 10 years of menopause onset, then the benefit risk ratio for hormone therapy appears favorable. Whereas that benefit to risk ratio is less favorable for women who initiate hormone therapy greater than 10 to 20 years after menopause, or when they're 60 years of age or older, due to that greater absolute risk of coronary heart disease, stroke, VTE, and dementia. So for those patients who have an absolute contraindication, or who you or they decide that risk-benefit ratio is just too great to consider hormone therapy, then we turn to non-hormone therapy. And that brings me to fezolinetant. Fezolinetant is the first drug that was specifically designed to treat hot flashes. It was approved by the FDA just about a year ago. And it blocks neurokinin B binding on the KNDy neuron. So normally estrogen helps regulate the KNDy neuron, but when we see estrogen decline during menopause, that leads to unopposed neurokinin B stimulation and heightened KNDy neuron activity. Fezolinetant blocks that, helps regulate it, and that all is important in the thermoregulatory center of the brain, so therefore it reduces hot flashes. This was studied in a couple of trials called the Skylight trials. They included women with a mean age of 54 to 55 years of age, predominantly white, but with 20% Black participants and 20% of participants who identified as Hispanic or Latina. And the time since vasomotor symptom onset ranged from a short 3 months to a long 396 months, with a mean of about 6.6 years. So kind of our classic patient who's showing up asking for treatment. In these trials, participants were experiencing an average of 10 to 12 vasomotor symptoms per day at baseline. And in the fezolinetant group, this was reduced to 4 to 6 vasomotor symptoms per day at week 12, which was 2 to 3 fewer than placebo. So we saw a really high placebo effect, which is pretty common in these sort of trials related to vasomotor symptoms, but fezolinetant outperformed placebo. And 60% of participants in the fezolinetant group experienced a clinically meaningful reduction by week 12. And clinical meaningful reduction is considered to be more than a 50% reduction in vasomotor symptoms. The onset was relatively quick. They saw onset of effect within a week. Full effect was seen within a month, and that was sustained for the duration of the trial, which in this case was a year. There's also some early evidence that fezolinetant might improve sleep as well as quality of life, which makes sense if we're reducing vasomotor symptoms. Fezolinetant is well tolerated. Headache was the most commonly reported, but this was reported also in a similar rate in the placebo arm. A previous drug in this class that was in development but never came to market was shown to have some liver safety concerns. And so liver safety was monitored very closely in trials. And they did see some rare increases in LFTs, but there was no evidence of drug-induced liver injury. but it is recommended to periodically monitor LFTs if you're using fezolinetant. I think the most significant barrier to use of this medication is going to be cost and coverage until that changes. Current coverage seems very limited in the United States, and the cost is at the same price I think any new drug is priced, unfortunately, in this country, which is about $500 a month. So if we think about Carol again, given this personal history of breast cancer, she has an absolute contraindication to hormone therapy. So we would need to consider non-hormonal treatment for her, and fezolinetant is one of those options. However, we also have others. There's a great position statement from the Menopause Society that was published in 2023 regarding the use of non-hormone therapy for menopause. This is an area where I feel like pretty much every non-pharm and pharm drug has been tried to see if it works. Most of them do not. So there are a number of options that are not recommended due to insufficient or negative evidence. Everything from cooling techniques and exercise and yoga and dietary modifications, which will help a lot of different things, but unfortunately not vasomotor symptoms. Mindfulness, paced respiration, relaxation, acupuncture, something called calibration of neural oscillations, chiropractic interventions, you name it, it's been tried, and unfortunately doesn't reduce the frequency or severity of vasomotor symptoms, but might help other things. So continue to recommend, just not for this. For pharmacotherapy options, pregabalin is not recommended, mostly due to risk of adverse effects and the fact that it's a controlled substance. Clonidine, suvorexant, as well as soy in various iterations, and all sorts of other supplements like pollen extract and rhubarb and black cohosh, you name it. And then finally, cannabinoids are also not recommended. And again, all of these are due to insufficient or negative evidence. Luckily, we do have several level 1 recommended non-hormone treatments, and level 1 means that they are based on good and consistent scientific evidence. This includes non-pharmacologic options like clinical hypnosis and CBT. Clinical hypnosis was shown to reduce the frequency and severity of hot flashes in a couple of trials and can be done either with a trained clinician or an app, which I found interesting. CBT did not reduce the frequency or severity, but did reduce the degree to which vasomotor symptoms are rated as a problem. So it helps people deal with them, which I think is true with most things in our lives. It helps people deal with them. In terms of pharmacologic options, gabapentin is a recommended option. The fezolinetant was added to this list and as an FDA-approved option, as I mentioned. Among SSRIs, there is a low-dose paroxetine that is the other FDA-approved option for vasomotor symptoms, however, is quite expensive. So in practice, when we're using SSRIs, we're using kind of our more commonly prescribed paroxetine at a lower dose, but I think would recommend preferably citalopram and escitalopram based on other risks of side effects, which have also been shown to be effective. And then the SNRIs, venlafaxine and desvenlafaxine. So when you see somebody like Carol in your practice who has an absolute contraindication to hormone therapy for vasomotor symptoms, this is the place to start, potentially through a shared decision-making conversation about risks of side effects, costs, availability, and potentially can combine a drug therapy option with hypnosis or CBT. Need to advance my slide. Here we go. Moving on to our next topic, Tony, age 77, has a history of pulmonary embolism, which was considered to be unprovoked in 2018. He also has hypertension and obstructive sleep apnea. He is on a nice short med list for a 77-year-old. Low dose cletholadone, rivaroxaban at 10 milligrams daily, and simvastatin. And you get one of our favorite faxes from insurance asking you to consider the safety of his medication. And specifically it says, quote, your older patient is receiving rivaroxaban based on claims records. And according to Beer's criteria, use of rivaroxaban for the long-term treatment of atrial fibrillation or venous thromboembolism should generally be avoided in older adults. Studies showed rivaroxaban to have a higher risk of major bleeding, in this population compared to other anticoagulants. This makes you ask yourself the question, should I be prescribing something different than rivaroxaban, or in this case, is it okay to continue the rivaroxaban? So to answer that question, let's look at the updated Beers criteria. So I think we're all probably familiar with what the Beers criteria is, but as a reminder, it's a list of potentially inappropriate medications that are typically best avoided in older adults. And a key word to remember is potentially inappropriate. So it's not a list of medications that should never be prescribed in older adults, but it's ones that have some evidence of increased risk and deserve some careful thought about the safety in the particular patient you're working with. And the intention of the Beers criteria, or Beers list, as we might call it, is to reduce older adult exposure to potentially inappropriate medications by improving medication selection, to educate clinicians and patients, and to serve as a tool for evaluating the quality of care, cost, and patterns of drug use. And it's intended to be applied to all adults who are 65 years of age or older in ambulatory, acute, or institutionalized settings, with the exception of hospice or end of life. So let's look at the noteworthy changes in this most recent update. First of all, several medications, 28 specifically, that were rarely or never used in the United States were removed from the main tables. This was an attempt to simplify and increase the usability of these criteria. It's not intended, or it should not be interpreted as condoning the use of these meds. They're still considered potentially inappropriate, but they were just moved off to sort of declutter. So this includes things like barbiturates that are not used or available on the US market, rarely used benzodiazepines like flurazepam and clozapam that are technically available but rarely used. So basically just some housekeeping. More substantive changes include the fact that aspirin for primary prevention has been moved from a use with caution to avoid initiating and consider deprescribing. This is consistent with other guidance and evidence that we've been published over the last several years, and I think is a pretty well accepted recommendation at this point. The recommendation to avoid use of sulfonylureas was expanded. In previous iterations, it was only applied to the long-acting glyburide and glimepiride, and now it extends to all sulfonylureas, given growing evidence that all sulfonylureas have an increased risk of hypoglycemia in older adults. SGLT2 inhibitors were added to the use with caution table. And again, this is not that SGLT2 inhibitors should never be used in older adults. Many older adults have a really compelling indication and would benefit from them. But the rationale for adding it to the use with caution is that older adults have been shown to be potentially at an increased risk of urogenital infections, especially in the first month of treatment, as well as an increased risk of the euglycemic DKA that is possible with the SGLT2 inhibitors. So we really need to think carefully about risks and benefits. And I think a key piece is to carefully counsel patients and monitor them to ensure the safe use of SGLT2 inhibitors in older adults. And then finally, and relevant to the case of Tony I presented, there were significant changes to the anticoagulant recommendation. So we'll look at those in a little bit more detail. So the first significant change was the fact that warfarin was added as a medication to be avoided, and specifically the recommendation is to avoid starting warfarin as initial therapy for the treatment of VTE or non-valvular atrial fibrillation unless alternative options, namely the DOACs, are contraindicated or are substantial barriers to their use. And this recommendation is primarily based on evidence of reduced risk of intracerebral hemorrhage associated with all the DOACs as compared to warfarin. And it's consistent with other guidelines that preferentially recommend DOACs for these indications. Taking a look at the evidence we have specifically in older adults, a meta-analysis pooled results from 6 post-hoc analyses of randomized controlled trials, as well as 6 longitudinal observational cohort studies to look at the safety and efficacy of anticoagulation in patients specifically 75 years of age or older. And they found that overall the DOACs outperformed warfarin. DOACs had a reduced risk of stroke and systemic embolism as a group, and as well as reduced risk of mortality with a similar risk of major bleeding and a lower risk of intracerebral hemorrhage. When they looked among the DOACs, they found that apixaban was consistently associated with the most favorable benefit risk profile across geriatric subgroups, which we'll come back to a little bit later in some of those other changes to the anticoagulant recommendations. So I think based on available evidence, it makes sense that DOACs are preferred over warfarin when you're starting therapy, but I think it's important to talk about the caveats to that. So one, in the main recommendation, it says that, it's unless there are substantial barriers to their use, and we all know that there is one substantial barrier to the use of DOACs, which is the cost of them as compared to warfarin. So if cost is the main factor driving this, of course, warfarin might be the best option. And it also doesn't apply to deprescribing or changing warfarin to a DOAC. So for older adults who have been using warfarin long-term, using it successfully, have a good high time in therapeutic range, aren't having adverse effects, then the benefit risk ratio is probably a little bit different than starting therapy, or in those folks who are not having great success with warfarin. And then finally, this recommendation, of course, does not apply to indications where DOACs are contraindicated and we need to use warfarin. The next significant change to the anticoagulant recommendations was a change to the rivaroxaban recommendation. So in the previous publication, rivaroxaban had a use with caution tag, and this time it was moved to avoid. So the new recommendation is to avoid rivaroxaban for long-term treatment of non-valvular atrial fibrillation or VTE in favor of safer anticoagulant alternatives. The rationale for this change is that observational studies as well as network meta-analyses have found that rivaroxaban is associated with a higher risk of major and gastrointestinal bleeding in older adults, and specifically as compared to apixaban and dabigatran. So looking at that evidence, this trial, investigators looked at a really large cohort of Medicare patients who are 65 years of age or older and had atrial fibrillation, over 500,000 in total. And they started following them when they were prescribed either apixaban or rivaroxaban. And then they continued to follow them for up to 4 years until they stopped filling that prescription, changed their anticoagulant, progressed to end-stage renal disease, or had an event or passed away. The median follow-up was 6 months, and the primary outcome was a composite of both major ischemic and hemorrhagic events. And what they found was that rivaroxaban treatment was associated with a higher risk of both ischemic and hemorrhagic events, as well as a higher risk of fatal and non-fatal extracranial bleeding and total mortality. These are all statistically significant differences, but do want to highlight that in terms of clinical significance, the absolute adjusted rate differences were quite small. So for that primary outcome, just 2.7 per 1,000 person years for that primary outcome. The highest absolute adjusted rate difference was for non-fatal extracranial bleeding, where we saw a difference in 21 per 1,000 person years. So for an individual patient, I think the clinical significance is small, but for that broad population, we saw preference for apixaban in terms of safety. This is similar to other trials which have also shown that rivaroxaban is associated with more major bleeding as compared to apixaban. Other investigators looked at rivaroxaban versus dabigatran. In this case, they again looked at this large cohort of Medicare beneficiaries who were 65 years of age or older and prescribed either rivaroxaban or dabigatran, and they followed them from time of initiation until they switched therapy or had an event or progressed to end-stage renal disease or died. A little shorter in terms of mean follow-up. And then in terms of those primary outcomes, they looked at thromboembolic stroke, intracerebral hemorrhage, major extracranial bleeding, as well as mortality. And again, they found that rivaroxaban treatment was associated with a statistically significant increase in intracerebral hemorrhage, major extracranial bleeding, and major gastrointestinal bleeding. So this is kind of where those recommendations for preference of either apixaban or dabigatran over rivaroxaban, it really comes from the risk of bleeding we see with rivaroxaban in older adults. However, again, in terms of clinical significance for individual patients, those absolute adjusted rate differences are quite low, 2.3 to 13 per 1,000 person years. So that brings us back to that recommendation we see in the Beers criteria to avoid rivaroxaban. I think when I'm choosing initial therapy, certainly would give preference to apixaban, given its kind of consistent evidence of kind of the best safety in older adults. But I think it's important to highlight some caveats to this. One, there might be circumstances where adherence, long-term adherence to a twice-a-day med just maybe isn't going to happen for a particular patient. And in that case, I would elevate rivaroxaban, given that it allows for once daily and still does have a reduced risk of intracerebral hemorrhage as compared to warfarin. It also should highlight that this recommendation does not apply to other indications or doses. So rivaroxaban does have several other indications used at lower doses. For example, the extended prophylaxis of DVT or PE, and this does not apply to that. It's specifically for that initial full dose treatment of non-valvular AFib or VTE. So looking back at, not quite back to look at Tony, one more thing about dabigatran. So dabigatran had a minor change. It was already on the use with caution list. Now it got expanded to say basically giving a preference for apixaban over dabigatran. I think the important thing to think about when choosing between dabigatran and apixaban is the impact of renal clearance. So dabigatran is the most dependent on renal clearance among the DOACs. And so I think that really can lead to an increased risk of accumulation in older adults with age-related kidney decline, whereas apixaban is the least dependent on renal clearance, which is probably why we see improved safety with apixaban. So now back to Tony. So again, you received this message from his insurance asking you to rethink about the safety of rivaroxaban and highlighting that it's recommended to avoid. However, I would say this does not apply to this patient. He is on a lower dose of rivaroxaban, which is appropriate for extended prophylaxis of DVT and PE. And we don't have evidence to say that using, for example, the low dose of apixaban that's also approved for that indication is safer than rivaroxaban. And he's doing well on it. So this is one that when I got asked this question, I said, okay, to continue the rivaroxaban in this case. Okay, moving on to our next patient to keep in mind. So Marlene, 52-year-old, has a history of NSTEMI twice in 2014 and 2019, had a 4-vessel CABG in 2014, also has diabetes, hypertension, and depression. Is on several medications, including max dose amlodipine bernazepril, low dose aspirin, high intensity statin, the renal dose of epagliflozin, basal insulin, max effective metformin, as well as a moderate high dose of semaglutide. And recent lipid panels showed HDL of 30 and LDL of 74. So in this case, let's start with looking at some of our most recent guidance in this realm, and then look at the more recent evidence regarding bempedoic acid and see if that changes place in therapy. So in 2022, the ACC published an expert consensus decision pathway on the role of non-statin therapies. The goal was to provide practical guidance for clinicians and patients in situations not covered in the 2018 guidelines, kind of as a stopgap until the next round of guidelines can formally review scientific evidence, and really wanted to help clinicians understand place in therapies for some of our newer non-statin agents. So kind of mirroring those 2018 guidelines, they provide nice, really useful algorithms for when we should be considering non-statin therapy in 4 patient groups: those with ASCVD who are using the statin for secondary prevention, those without ASCVD but with a baseline LDL of over 190, those with diabetes on statin for primary prevention, as well as those primary prevention patients without ASCVD or diabetes. And then within the secondary prevention group, they break it out into those at very high risk, not at very high risk, those with familial hypercholesterolemia, and those without. So in order to know which algorithm to look at and follow, then you need to identify whether your patient is at very high risk or not at very high risk. So very high risk is defined as a history of multiple major ASCVD events or one major ASCVD event plus multiple high risk conditions. So if we apply this to our patient, she's had history of NSTEMI ×2 as well as multiple high risk conditions. So she would definitely meet criteria as a very high risk patient. So we would look at that algorithm, and one of the big changes in this expert consensus decision pathway is a change in our LDL goal or threshold for when we should be considering non-statin therapy. So you can see here that for those very high risk patients, we want to see if they've met that 50% LDL reduction, as well as an LDL of less than 55 or a non-HDL of less than 85. This non-HDL threshold was included because studies have identified a high correlation between ApoB and non-HDL. And non-HDL can be simply calculated from just subtracting the HDL from the LDL, or excuse me, the HDL from the total cholesterol on a routine lipid panel, and can provide kind of an inexpensive surrogate or way to assess the all atherogenic lipoproteins. So again, big change, having this lower LDL threshold of, instead of less than 70, less than 55 for our highest risk patients. In addition to these very high risk patients, this lower goal also applies to those with familial hypercholesterolemia. So if your patient does meet these criteria and kind of is below these thresholds, then great, mission accomplished, well done. Monitor adherence to those lifestyle modifications, medications, continue to periodically monitor LDL, and consider treatment of persistent hypertriglyceridemia if needed. However, if they don't meet that threshold, then that's where you're going to need to evaluate and optimize lifestyle modifications, perhaps refer them to a dietitian. You're going to evaluate and optimize adherence to the statin, and if necessary, increase to high intensity statin. If after optimizing statin therapy as well as lifestyle modifications, they're still not, if after that they're meeting those thresholds, then great, monitor. If they're still not meeting those thresholds, that's where we want to consider non-statin therapy for these very high risk patients. And this expert decision pathway recommends preferentially considering ezetimibe or a PCSK9, a monoclonal antibody, and then if additional LDL lowering is needed to get to threshold, bempedoic acid or inclisiran. So I want to take a little closer look at these non-statin therapies. So in the 2018 guidelines, there was a preferential recommendation for ezetimibe, primarily based on cost. Cost has improved significantly, as well as we now have cardiovascular outcomes data related to the PCSK9 monoclonal antibodies. So coverage has also improved with the cost. And so I know personally, it's all still stuck in my head that these are sometimes out of reach for most patients, and you need to be prescribed by a specialist, and you're going to need to jump through a million hoops. That is really changing. I looked at Providence Health Plan's PA criteria just recently for these, and for as all PA criteria, it really depends on which line of business. So it's going to be different if you have a Medicare patient or a Medicaid patient or a commercial patient. But for most lines of business, most patients, they've taken out the specialist requirement for prescribing, and they've taken out the requirement to try ezetimibe first. And so they really are, I think, my take-home message is don't just assume they're out of reach for patients if they're the right drug based on their risk. So thinking about, since we're talking about the PCSK9 monoclonal antibodies, we'll stay there. So these provide really potent LDL reduction, as we know, 50 to 60% on top of a statin. And they were shown to provide additional cardiovascular benefits. So in alirocumab's trial, it was added to evidence-based statin therapy in post-ACS patients and showed a reduction in cardiovascular outcomes. In the evolocumab trial, they added it to folks on statin who had a prior MI or stroke or peripheral artery disease, and also showed a further reduction. Ezetimibe is also a good option. It provides more modest LDL lowering, probably in the 20% range, but did show additional reduction in cardiovascular outcomes when added to a statin. So again, kind of overall, they are considered to be an either or recommendation, but you might consider ezetimibe if folks are closer to goal, because just thinking about how much LDL lowering you're going to get. So if they're within 25%, if they need just less than 25% more LDL lowering, that could be a good option. If they've had a recent ACS, just based on who was included in their trial, Or of course, if cost is a consideration, because while the PCSK9 inhibitor costs have gotten better, they're still very high cost, whereas ezetimibe is very low cost. So there is certainly obviously still a very big difference. Or if a patient strongly prefers an oral drug. Whereas I think the main reason to consider a PCSK9 monoclonal antibody is if you need significant LDL lowering, since they are potent LDL lowerers. In the decision pathway, kind of second tier, if you need more LDL lowering after ezetimibe and a PCSK9 monoclonal antibody, we saw bempedoic acid and inclisiran. When this pathway was published, neither one of these had cardiovascular outcomes data. That has since changed for bempedoic acid, which I'll present here next. Inclisiran, we're still waiting. Inclisiran is a PCSK9 inhibitor that acts intracellularly. So it would be an either or. So you wouldn't use inclisiran on top of one of our usual PCSK9 monoclonal antibodies. It would be an alternative to. And kind of the niche that it might take up is it is a twice a year medication administered in the office. So for folks who cannot adhere to a kind of traditional PCSK9 inhibitor or have do not tolerate a traditional PCSK9 inhibitor, that might be a nice option that you can just give twice a year. But cost and the lack of cardiovascular outcomes data really precludes its use at the moment. But bempedoic acid, we do now have cardiovascular outcomes trials. So just as a reminder, bempedoic acid is a prodrug that inhibits ACL. ACL is an enzyme that's just higher up in the same pathway where statins work. It's a once-a-day oral medication. It was approved back in 2020, but at that point didn't have cardiovascular outcomes trial. And perhaps I'm just pessimistic, but it too has the same price tag as every other new drug. When studied as monotherapy, it provided sort of modest LDL lowering, kind of similar to ezetimibe, kind of in that 20% realm. When used as a fixed combination with ezetimibe, it provided more, about 38%. And its kind of claim to fame is that it doesn't have the muscle-related side effects as statins. It is a prodrug that has to be activated to its active form in the liver. It doesn't have any activation in the muscles, and as a result, in trials was shown to have muscle-related symptoms exactly the same or even a little less than placebo. It also doesn't seem to have the same risk as of increasing glucose or exacerbating diabetes as statins do. The one adverse effect that was seen more often was gout. It was a slightly increased risk of gout. The overall incidence is still low, just 1.5%, and it seems like this risk can probably be mitigated by ensuring patients that have pre-existing gout have well-controlled uric acid prior to starting therapy. So as I said, we were waiting for its cardiovascular outcomes trial, which we now have. This was published last year. And in this trial, about 14,000 statin intolerant patients were randomized to either bempedoic acid or placebo. In order to be included, they either had to have a history of cardiovascular disease or be at very high risk of cardiovascular disease. So a kind of mix of primary and secondary prevention. The median follow-up was 3 years, and the composite was our traditional 3-point MACE outcome. 4-point MACE outcome with the coronary revascularization. And they found that the incidence of this primary endpoint was significantly lower with bempedoic acid, with a number needed to treat of 63, which is kind of in the realm of some of our other agents in this class in terms of cardiovascular risk reduction. So how does this change place in therapy? To be honest, I'm not sure it changes it a lot. For patients with clinical ASCVD, so that patient we were talking about that was very high risk, if the LDL-C or LDL is greater than that desired threshold on maximal statin therapy, I would still preferentially add the ezetimibe or the PCSK9 monoclonal antibody, given that they have shown reduction in cardiovascular risk in addition to a statin in these high-risk populations. But if additional LDL lowering is still needed to get to that threshold, then certainly I would choose bempedoic acid next, given this new evidence. And then for folks with statin-associated side effects, of course, we should re-challenge them with a reduced dose or alternative statins. We know that most patients can tolerate a statin. It just might not be the first statin we chose. But if they are recurrent or severe, then we should, of course, use non-statin agents. But again, I would start with ezetimibe or a PCSK9 inhibitor, especially depending on how much LDL lowering is needed to get them to goal. We might need to go to a PCSK9 inhibitor since both ezetimibe and bempedoic acid provide much more modest LDL lowering. But if a patient strongly prefers oral therapy, there might be a role for bempedoic acid, either with or without ezetimibe, and it's available with ezetimibe in a fixed dose combination for additional LDL lowering as an oral agent. So looking at back at Marlene, we identified that she certainly qualifies as a very high risk patient with a history of ASCVD. She is on high intensity statin, so I'd want to ensure she was adherent to it, ensure she's following lifestyle recommendations. If we optimize all those things and we still have this LDL at 74, she's kind of right at that threshold where we might choose ezetimibe because she's right about needing 25% more lowering to get to 55, and ezetimibe certainly is a lot less expensive. If that LDL was more like at 100, that's where if she needs more than that 25% lowering we're going to get with ezetimibe, we would want to pursue a PCSK9 monoclonal antibody in this case to get her to an LDL of less than 55. All right, next up, we have David. David is 74, has a history of NSTEMI with PCI in 2017, also has type 2 diabetes, hypertension, and moderate persistent asthma, is on several medications, including a beta blocker highlighted with metoprolol succinate. His last 3 blood pressures appear pretty darn well controlled. So let's talk about beta blocker use after myocardial infarction, keeping David in mind. So beta blockers have been an essential part of secondary prevention after MI, as we all know, since studies in the 70s and 80s in this pre-reperfusion era demonstrated significantly lower mortality associated with beta blocker treatment. But obviously lots has changed since the 80s. In the data from the reperfusion era, after we've implemented immediate reperfusion therapy as kind of a mainstay, after we've implemented the use of antiplatelet drugs and statins and RAS inhibitors, which we all know reduce cardiovascular mortality and morbidity in patients with acute MI, we have very limited data. And we know that beta blockers are not benign. They're associated with several side effects, including depression and fatigue. So reevaluating their long-term use in these patients, I think, is justified. In a South Korean cohort of 12,000 patients, in a pretty recent study, so definitely in the reperfusion era, patients who were hospitalized for acute MI, those who were prescribed a beta blocker at discharge did have a significantly lower 1-year risk of major adverse cardiovascular events, but there was a significant interaction with left ventricular ejection fraction. So in the total population, we saw a benefit. When we looked at stratifying them by left ventricular ejection fraction, the red line there is the risk, those patients who were prescribed a beta blocker at discharge, and we can see a significant difference in those who were and were not prescribed beta blockers. On the left panel, we see left ventricular ejection fraction of less than 40%. In the middle, we see those with kind of mildly reduced, so between 40 and 50%, and we still see a difference in those lines. But in those folks with ejection fraction of greater than 50%, we see the lines are essentially on top of each other, no real benefit seen in that cohort. Another study looking at beta blocker therapy after myocardial infarction was published in 2022. This was a meta-analysis of 5 studies, all published after 2020, which included over 200,000 patients with myocardial infarction, but specifically excluded those with clinical heart failure. They looked at follow-ups of 1 to 3 years, depending on the trial, and all of them looked at all-cause mortality. And the pooled estimate found that oral beta blockers, compared with no beta blockers at discharge, were not associated with a reduction in the risk of all-cause mortality. Or in other words, beta blocker use of at least 1 year did not reduce the all-cause mortality compared to just no beta blockers. Kind of a little different spin on this would be looking at the duration. So this is a recent trial that was a Swedish cohort of over 43,000 patients with a history of MI, but again, specifically excluded those with heart failure or an ejection fraction less than 50%. The follow-up started 1 year after the event, 1 year after the MI, and then continued for a median of 4.5 years. And they looked at that composite of all-cause mortality, MI, unscheduled revascularization, and hospitalization for heart failure. And in this case, they found that after adjustment for pre-specified variables, the risk of the composite cardiovascular outcome was no different according to beta blocker treatment. So again, this suggested that beta blocker treatment beyond 1 year after MI for folks who didn't have heart failure or didn't have left ventricular or reduced left ventricular ejection fraction was not associated with improved cardiovascular outcomes. And this new evidence has been incorporated into our most recent guideline. So this guideline was published last year for the management of patients with chronic coronary disease. And we see that in folks who, of course, have a reduced left ventricular ejection fraction of 40% or less, then with or without MI, of course, then we should be using beta blocker therapy to reduce the risk of future adverse cardiovascular events. They also recommend a preference for those beta blockers we know have been shown to be effective specifically in this indication, so metoprolol, succinate, carvedilol, or bisoprolol. However, for folks with chronic coronary disease who were initiated on a beta blocker for previous MI, but who do not have a history of kind of other indications, so who do not have a history of or current left ventricular ejection fraction of 50%, do not have angina, arrhythmias, or uncontrolled hypertension, then it may be reasonable to reassess the indication for long-term, meaning greater than 1 year, of beta blocker therapy for the purpose of reducing adverse cardiovascular events. And then finally, in those patients with chronic coronary disease who do not have a previous MI and who do not have a left ventricular ejection fraction less than 50%, then kind of the use of beta blocker therapy at all is very questionable and considered not to be beneficial in reducing major adverse cardiovascular events unless they have another indication, of course, so unless they have an arrhythmia or angina that you're treating. So applying this evidence and these guidelines to David, we see he had a MI, but several years ago, and does not have a history of a reduced ejection fraction, does not have angina, does not have uncontrolled hypertension. So in this case, I would feel very comfortable titrating off or discontinuing his beta blocker. And last but not least, let's talk about Gary. Gary is a 60-year-old. He has a BMI of 40. He also has peripheral artery disease, hypertension, HFpEF, and prediabetes. He is on a few medications: clopidogrel, empagliflozin, olmesartan, and rosuvastatin. If your patients are like patients I've been seeing, probably watched Oprah's special and wants to talk to you about a GLP-1 agonist. So before I talk about the evidence, I certainly want to highlight, I think, the wonderful grand rounds we had a few months ago, re-examining our assumptions around weight. And I think it is a very nuanced conversation that we need to be having with patients, and it's not, I kind of make light of the fact that everybody's asking for these medications, but I think it is a really nuanced conversation and would highly recommend watching that. It's certainly thought-provoking for me, but do want to highlight today the evidence regarding this class of medications, specifically semaglutide, in folks who have obesity and some other indications, so and a history of cardiovascular disease or HFpEF. So starting out with the study that looked at cardiovascular disease and obesity. So this study included 17,000 patients who were 45 years of age or older, had pre-existing cardiovascular disease, but did not have diabetes, and had a BMI of 27 or greater, and they were randomized to semaglutide 2.4 milligrams per week, which is the weight loss dose, and then or placebo. The follow-up had a median of 3 years, and they looked at our 3-point MACE outcome composite of death from cardiovascular causes, non-fatal MI, or non-fatal stroke. And they found that semaglutide was associated with a lower risk of the primary cardiovascular endpoint, with a number needed to treat of 67. And as a result of this study, semaglutide that is specifically for weight loss, so that's Wegovy, the Wegovy product, has been approved for this indication, and that is changing coverage of it, which we'll talk a little bit about. We'll talk more about kind of the risks. These are certainly not benign medications, and in this study specifically, they did see adverse events leading to permanent discontinuation was more common in the semaglutide group, about double, so 16.6% of patients discontinued permanently due to adverse effects. The other trial that was published pretty much at the same time looked at semaglutide in HFpEF and obesity. This was a much smaller trial. 500 patients with HFpEF and a BMI of 30 or higher were randomized to the semaglutide 2.4 milligrams per week or placebo. They followed them for a year, and they looked at a couple of outcomes, change from baseline in the KCCQ CSS score. That score goes from 0 to 100. Higher scores mean lower symptoms and less physical limitations. They also looked at body weight, and as a secondary outcome, they looked at change in the 6-minute walk difference. And what they found was that semaglutide was associated with a significant increase in the KCCQ CSS, about double that of in placebo. And just to put that into context, a difference of or an increase in 5 points is considered a small change, but clinically significant. Increase in 10 points is considered a moderate clinically significant change, with a 20-point increase being a large change. So this would be kind of provided a moderate improvement, a moderate increase or improvement in their physical limitations and symptoms. There was a significant reduction in body weight, which is not surprising. And then as a secondary outcome, they looked at 6-minute walk difference, and they found a significant increase. In the semaglutide arm, they saw an increase of 21 meters versus just 1.2 meters in the placebo arm. And based on previous studies, differences of 15 to 20 meters is considered kind of the lowest threshold for clinical significance. So kind of did probably make a clinically significant improvement in that 6-minute walk distance. So thinking about Gary, he certainly kind of meets criteria. He would have been included or could have been included in these trials. He has a BMI of 40. He has history of cardiovascular disease with peripheral arterial disease. He has HFpEF. So I think a shared decision-making conversation about potential benefits, maybe some of his functional status with that HFpEF, seeing if those changes we saw in the HFpEF trial would be meaningful for him. And then, of course, would need to consider cost and coverage. So just to give you some historical reference and to help differentiate, I think it can get very confusing when we're talking about these agents because these are all drugs that have been approved and used in diabetes, but there is a difference when it comes to coverage and product. So semaglutide, which we've been talking about, both of those studies were with semaglutide. They used the dose that is approved for weight loss, which is Wegovy, not Ozempic. And so when you're thinking about cost and coverage, that matters. As far as administration, it's all going to be about the same weekly administration, similar weight loss that we saw with the diabetes product, of course. Liraglutide, the weight loss product, is Saxenda. That was approved much earlier, I would say, because of its daily administration, not nearly as frequently used, less weight loss. And then the most recently approved GLP-1 for weight loss is tirzepatide. Again, for diabetes, this is Mounjaro, but when approved for weight loss, it is Zepbound. Can't make these names up. Definitely more weight loss if I had to compare them with semaglutide, but doesn't have those cardiovascular outcomes data, and so that does affect some of the coverage. So I mentioned coverage is changing. Historically, Just as an example, Medicare was a no way, no how, no weight loss drugs are covered. That has changed with this new indication for semaglutide. And so Providence Health Plan, as the kind of local example, has updated their coverage for semaglutide, specifically Wegovy, in the Medicare population if they meet kind of the exact criteria that were included in that trial I presented. That doesn't mean they're affordable. Coverage does not mean affordability, but I think as a whole, there's still very limited coverage for weight loss medications, but I do think some of this cardiovascular outcomes trial might be shifting that a little bit for what it's worth. The other thing I want to touch on before I leave at least a couple minutes for questions is the fact that these are not benign drugs and require a lot of consideration before prescribing, whether that be for diabetes or weight loss or cardiovascular risk reduction. First of all, they are contraindicated in a few situations. So personal family history of medullary thyroid cancer or multiple endocrine neoplasia syndrome type 2. I also am cautious about their use if kind of a history of chronic recurrent pancreatitis. They are also linked to increased risk of cholelithiasis, cholecystitis, and biliary disease, which kind of is a growing appreciation and should be considered. I'm in a loop. There we go. GI side effects are common at initiation or dose increase. They are often mild and transient, but not always, and they can be really severe. So we have certainly seen situations where patients not only are uncomfortable, but presenting to the emergency room because they are throwing up and not sure why. So I think really careful counseling and follow-up is really important to avoid the not necessarily avoid the adverse effect, but help patients know how to handle and manage the adverse effect if it happens to them. But it can be dose limiting, and often, maybe 15%, 20% of patients are going to have to stop the medication because of it. I especially am cautious in folks with pre-existing gastroparesis because it can be particularly severe if they exacerbate that. I don't know what's happening to my slides. Here we go. And then finally, cost, which I think I have touched on enough to not say anymore, but these are expensive drugs and coverage doesn't necessarily mean affordability, unfortunately. Okay, and with that, not enough time probably, but a little time for questions.
Wow, many thanks, Dr. Fry, for covering a wealth of information. I'm going to return us to the very first case on vasomotor symptoms from a question here online. This is a provider who inherited an 82-year-old woman on oral estrogen, 1 milligram twice a day. Given some of your mention of older age and such, an attempt was made to wean dose and potentially off this medication with return of menopause vasomotor symptoms when at a dose of 0.5 milligrams daily. The patient requested gyne referral where she was re-prescribed 1 milligram twice a day. Curious, and which we've been there, right? So, but curious, sort of nuance of any thoughts that you might have. I know a little peripheral to your talk on ongoing dosing and duration of hormones at a more advanced age.
Yes. I think, what would I say about that? I think I would wonder when it was started, because I do, I think continuation certainly has its risks, but it certainly, I think, be even most risky if it was kind of started really late. I would want to have a shared decision-making conversation with the patient, right? Because they are certainly involved in that and kind of making sure they understand the risks that probably this prescriber and all of us in the room, based on the reactions, we're concerned about. And then I do think I would want to explore potential to reduce some of those risks if it was really clear the patient needed to, wanted to, et cetera, continue hormone therapy, about using topical products to reduce some of the risk, which again, kind of related to cost, often were out of reach, but is no longer the case. There's a lot of pharmacists in this room today because my department has a meeting afterwards. It's certainly open to other thoughts from the crowd and prescribers as well. But those are the things I would be, I think, thinking about and trying to do.
Great, we will take it. And at that, I want to respect that we are right at 9 o'clock. Thank you so much, Dr. Fry, for your excellent teaching.